Mr. Chairman, dear colleagues, dear friends, thank you very much. I will present today our preliminary results on a multicenter trial we designed a few years ago. So what we know is that the recurrence on pancreatic remnant after partial resection for IPMN of the pancreas is different looking for benign IPMN or malignant IPMN with an increased risk of recurrence in malignant compared to benign one, and the overall risk in general reported by literature in recurrence in resected IPMN is about 10% with the risk of cancer around 2%. The problem of all those studies are generally that are based on a small group of patients, so no big multicenter trial are available today, and sometimes with a relative short follow-up, in particular for benign lesion resected. And we know that the natural history of this lesion is quite long. So the aim of our study was to analyze the natural history of pancreas remnant and patient after partial pancreatectomy for IPMN, and to define who, when, how, and how often should patient be followed after partial resection for IPMN. If you look today, the two biggest guidelines available, so the International Association of Pancreatology guideline and the European guideline of cystic tumor, the follow-up strategy is quite different, but not based in both guidelines on evidence. So we have a leak of data supporting our guideline. So what we decided to do was to build a large multicentric international retrospective database of patients undergoing partial pancreatectomy or eventually enucleation for IPMN of the pancreas, and then trying to analyze data like, for example, IPMN type, branch dot, main dot, mixed type, multifocal, unifocal, histology, so which kind of histology of IPMN we have, the stage of disease, the marginal status, and eventually post-operative radiological sign of recurrence. So that was a very difficult process, and we will see in a while many centers participated. We are still waiting for some small data remaining. So what you see today are the data we have available and the results we have available at that moment. This study was possible because this is an example of joint venture between two groups. The first one, where the study was designed, is the European Study Group on Cystic Tumor of the Pancreas that made the European guideline in 2011. And in 2012, we start to build this group. And then in 2012 or 13, now I don't remember perfectly well, we joined. And we had the honor to present this study in the Verona Expert Consensus Conference meeting. From that moment, we joined together this project, and we worked together to make this group bigger, and this study bigger and bigger. And if you see this map, you can see that probably we reach our goal, because there are centers, mostly in Europe, of course, because there is where the study is born, but also United States and India participating to the center. So overall, we collected 1,686 patients underwent partial pancreatectomy for IPMN. You can see that more or less the ratio from male and female is the same, with the mean age 66 years, which is the median age of IPMN resected. Most of these patients receive a pancreatic duodenectomy, 20% distal pancreatectomy, and then few patients central pancreatectomy, enucleation, or other atypical procedure. And we have a very long follow-up. The median follow-up is 5 years, but we have many patients that have follow-up even over, including 10-year follow-up. So the morphology type were operated, as you can see here, was 40% branch dot IPMN, mostly the same for a mixed type, and 21 main dot. That is quite surprising, but if you put together mixed type and main dot, you can see that the majority, as is normal, are lesion involved in the main dot. What is also interesting is that 45% were cancer at the moment of histology. The overall recurrence rate in our patient was 15.7%, including every kind of recurrence. So including local recurrence in the remnant, new onset or progression, and distal metastasis in cancer ones. So you can see the majority of patients has a new onset, as a pancreatic remnant recurrence. 2% has liver metastasis in malignant IPMN. And then you can see you have some few cases of peritoneal carcinomatosis or local recurrence. What is interesting to see in our experience as well, when we look for malignant lesion, including high-grade dysplasia patient, the risk of recurrence, or at least this is not a risk, the percentage of patients experiencing recurrence is around 20% compared with 11% of benign lesion, with a statistically significant difference. The rate of reoperation for recurrence was 3.5%, and this risk to be reoperated during the time is increasing by time. That is quite logical. That means that we did the right operation from the beginning. So there are very few patients who were operated, needed an operation shortly after the first operation, but mostly of the patients require operation are after 5-6 years of observation. What about the risk of progression by morphological type? Well, in our analysis, mixed type IPMN were the patient with higher risk for recurrence after surgery compared to main DAT and branch DAT IPMN. Regarding the histotype risk of progression, pancreaticobiliary histotype was associated with a statistically significant higher risk for recurrence compared to the other histotype. And finally, this is quite logical, when we had the positive margin at the resection, the risk of recurrence was higher compared to the patient without a positive margin. In conclusion, the recurrence rate is higher in malignant IPMN. This is a data that actually we know before, even if smaller series. And the risk of reoperation for progress on new onset IPMN become higher after 5 years. That's an important implication, because when we plan the follow-up of our patient, we should take in consideration that follow-up costs. IPMN is a frequent disease, and probably we can be less aggressive in the first 5 years compared to what we should do after 5 years of our resection. Finally, mixed type IPMN, pancreaticobiliary histology, and a positive resection margin should be considered risk factor, and for this reason, those patients probably need a more aggressive follow-up. Thank you very much for your attention.